Assalamu alaikum. I'm the host of this session. My name is Dr. Azhar. I'm from Aga Khan University Hospital. Today we have our esteemed guest, Dr. Uzma Yousaf. She will present a very interesting topic, how to ensure patient safety perioperatively. Dr. Uzma did her FCPS in anesthesiology from the Indus Hospital, and currently she is working as a senior registrar in National Hospitals, Lahore. So there is a famous quote regarding the perioperative medicine. Vigilance in perioperative monitoring is the silent guardian ensuring the symphony of surgery plays smoothly, orchestrating patient safety with precision. So before we proceed, I will request all the listeners to please switch their mobile phone or their devices on mute mode, their microphone, and at the end of the this talk, link will be shared for the feedback. So for certificate, it is mandatory to submit the feedback. Dr. Uzma, you can start now.
Okay. Good evening, everyone. This is Dr. Uzma Yousaf. I'm the Senior Registrar at National Hospital, Lahore. Today, my topic for presentation is how to ensure patient safety perioperatively. It's very important when the patient is here with us and we are giving them anesthesia. It's all upon us to ensure the safety. And for that purpose, we have to monitor any physiological changes and if the patient is going through any pathological changes during the anesthesia. For that thing, we do the monitoring for the patient. It is very essential component of anesthesia care because it encourages the quality patient care. When there is surgery is going on, when the patient is going through the anesthesia, when there is the induction of the anesthesia, patient went through a lot of physiological variables and anesthesia equipment. There are the changes like hypotension, there can be hypertension, and this can be done due to some changes, pathological changes, and the different drug reactions. For that thing, we have to be very vigilant and monitor patient care. Patient and equipment monitoring is used to titrate the administration of the anesthesia medication and to detect the physiological perturbance and allow intervention before the patient suffer harm and to detect and correct the equipment malfunction. Why do we need monitoring during anesthesia care? This is for the patient safety because the normal physiological hemostasis should be maintained for the patient, early detection of the pathological changes, to prevent the hypo and hyperthermia during the procedure, and to prevent the hypo and hypertension during the conduct of anesthesia. And these all changes can occur during the anesthesia, induction, maintenance, recovery, as well as in the post-op care area. Surgery is very stressful procedure, and physiological, pathological changes during the surgery like sympathetic stimulation, arrhythmias, hypertension can occur. And there is also the hemodynamic instability, myocardial depression, hypotension, and hypertension during this conduct of anesthesia. That's why there are standards that are maintained by the American Society of Anesthesiology, and they are standard 1 and standard 2 safety cares. In standard 1, we have the qualified anesthesia personnel. Why we need anesthesia personnel? Because if there is the rapid change in the patient status during the anesthesia, that person should be there to detect that change and have to do prompt action for the correction of that change. It should be continuously present to monitor the patient, and it should be there. Anesthesia resident and registrar can be there, but anesthesia trainee should be monitored and supervised by the consultant. excuse me. Um, Continuous presence of the appropriate trained and suitably experienced anesthetist is the cornerstone of the patient's safety during anesthesia. The anesthetist should be with the patient all the time, at least with the until the WHS sign out has been completed and the patient care has been handed over to the appropriate training staff. It is because the clinical correlation and judgment is important, better, and much more valuable than digital monitoring. Modern monitors have made our life easy, but the presence of the specialized anesthesia personnel cannot be, the importance of the anesthesia personnel cannot be omitted. That's why this is called the standard one. Then we have the standard 2 monitors. These monitors are used to monitor the different modalities in the patient care, like oxygenation, ventilation, circulation, and temperature. And for that purpose, for the oxygenation, we need inspired gas analyzer and pulse oximetry. Oxygenation is necessary to ensure the adequate oxygen concentration in the inspired gas and the blood during all anesthetics. Excuse me. And during every administration of the general anesthesia using anesthesia machine, the concentration of the oxygen in the patient breathing system shall be measured by the oxygen analyzer with the low oxygen concentration limit alarms. During pulse oximetry, it gives us the information about heart rate, saturation, and perfusion index. I will discuss it later. For inspired gas analyzer, it should be used to ensure that the hypoxic mixture of gases is not delivered. Analyzer should be calibrated before each anesthesia is administered. And alarm should be set so that we can make sure that there is no delivery of the hypoxic gas mixture. Analyzer should be calibrated for air, 21% of the oxygen, and 100% of the oxygen. It should read at least 21% before every anesthetic is administered. Oxygen analyzer usually have a low level alarm that is automatically activated by turning on the anesthesia machine. The sensor should be placed into the inspiratory or the expiratory lamp so that the patient will not get the hypoxic gas mixture. It is necessary to ensure the measurement of the concentration actually delivered to the patient rather than dialed concentration. Pulse oximetry. Pulse oximetry is the quantitative method of assessing the oxygenation that should be used when possible during all anesthetics and is the part of the World Health Organization pre-operative safe surgery checklist. In some cases, when we cannot put a pulse oximeter, like in children or very irritable patient, it should be monitored as soon as the patient is unconscious. The patient is given the anesthetic, and the reason why there is the delay for the putting on the pulse oximetry, it should be recorded. Oxygenation is called as the fifth vital sign along with the respiratory rate, heart rate, blood pressure. It is because it tells us the how much oxygen is in our body, and it's basically the surrogate marker for tissue oxygenation. It is non-invasive device used to detect the oxygenation and heart rate called the pulse oximeter. And there should also, the volume should be high enough so that we can easily detect if there is any change in the pulse oximetry, if a change in the heart rate, if there is any change in the saturation. This is the device that is attached to the finger. The principle for the pulse oximetry is spectrophotometry. It works on the principle of spectrophotometry. It absorbs the infrared or red light for the oxygenated blood or deoxygenated blood. Basically, it determines the proportion of the hemoglobin that is saturated with oxygen in peripheral arterial blood. Two different wavelength light, such as that are 660 and 940 nanometer. These are absorbed. At one side, there is the luminous emitting diode, and the other side there is a detector that detect how much light is absorbed, and it is digitally present, and the waveform is made on the monitor. Oxygenated and deoxygenated hemoglobin in the ratio of the light absorbance between oxyhemoglobin and the sum of the oxyhemoglobin plus deoxyhemoglobin is calculated and compared to establish an estimated measure of the peripheral arterial blood saturation. And the result is shown as the graphical representation as well as the numbers of the saturation on the monitor. And pulse oximeter follows the Beer and Lambert law. This law states that the absorption of the light of a given wavelength passing through a non-absorbing solvent, which contains an absorbing solute, is the proportional to the product of the solute concentration, the light pathway length, and extension coefficient. There are different types of probes that are used. There are different type of probe that are used for the pulse oximetry. These are finger probe, ear probe, even forehead probe is also used. And there are also the transesophageal probe that are used for the detection of the oxygen in the blood. The other option is nasal ella. Infant mein we use the palm probe. We use the probe that can fit on their feet, arm, and nasal septum. Forehead probe has the emitter and diode adjacent to each other so that the saturation is measured from the light that is reflected from the bone, from the part of the forehead, and to the exposed tissue, and it can be detected. These sites are preferably used since it contains the high density of the vessel tissue. These are different types of probes they are showing us. Now, I can tell you the advantages, disadvantages, and limitation of the pulse oximetry. The advantages are it's very rapid, non-invasive. It provides the continuous data about heart rate, saturation. It is very safe and convenient. Beat to beat variation can be detected by the pulse oximetry. Perfusion index can also be detected with this. And what is perfusion index? Basically, this is the ratio of the pulsating to the non-pulsating blood that is present in that part of the area where the pulse oximeter is applied. It tells us how much perfused is that part of the body. And there are limitations for the pulse oximetry. It doesn't tell us whether the amount of oxygen in the blood is high or low. It doesn't tell us if there is hyperoxemia. Uh, because at the certain level, when there is the change in the partial pressure of oxygen, the saturation of the blood is not changed at certain limit. When there is the large change in the partial pressure of oxygen, then there will be it will be shown as the saturation change. It will not be able to measure arterial blood oxygen tension. And it also unable to measure the ventilation. It will not tell us whether the patient is hypoventilated or hyperventilated. These are the limitation for the pulse oximetry. And these are the information that we get from the, pulse oximeter. These are saturation, that is blood oxygen, heart rate, that is shown by the graphs, and it also shown as the digital in the number form. And there is the perfusion index. The value for the perfusion index is 0.2 to 20%. This is not shown nicely. There are the, in some, there is some condition when there is not proper reading for the pulse oximetry. That can be, I think it's not shown properly. There is something. If the position of the probe is malposition, if there is a motion artifact, if there is the hypoperfusion of the site, and if there is the hypothermia, if there is skin pigmentation is different, then there will be inadequate waveform will be formed. In that case, we have to change the position of the probe, and we have to get some alternate site to get the proper pulse oximetry. In that case, we can use the earlobe, forehead probe, even transesophageal probe can be used, but it's not very much in use in our country. And if there is the skin pigmentation issue, we can use the arterial blood. We can get the arterial blood gases for the to get saturation and partial pressure of the arterial gases. If there are some kind of pathological problems like carboxyhemoglobin, or if there is some kind of methemoglobinemia, or there is some ambient light issue, then we can do the co-oximetry. We can get the arterial blood gases, and we can remove the ambient light source. So we can get the reading for the correct reading for the pulse oximetry. If there is the low oximeter reading, just such as in methemoglobin, sulfhemoglobin, in some kind of diseases such as sickle cell disease, severe anemia. In that cases, we can get the biochemical analysis. We can get the hemoglobin S measurement. And in case of anemia, we can get the arterial blood gases. These are the troubleshooting for the RNS pulse oximetry readings. Now we have the other modality, the other standard for the monitoring, that is ventilation. Why ventilation is important? If the ventilation is not adequate, there will be collection of the carbon dioxide gas in your body. And if the patient is hyperventilated, the more CO2 is exhaled out, and where there will be hypocarbia, and it will change your cerebral circulation. And there are much more different aspects that can be shown. So for the ventilation, we use the capnography, and it ensures us the adequate ventilation of the patient during the anesthesia. It should be used continuously during the anesthesia, and it can also be observed by the clinical signs such as the chest movements, auscultation of the breath sound, and movement of the reservoir bag in case of the spontaneous ventilation. But to know the adequacy of the ventilation, we need our digital monitor, that is capnograph. Patients who are spontaneously breathing should be observed the sign of airway obstruction, including the tracheal tract, paradoxical chest movement, if patient is snoring, if there is upper airway sound. And equipment that is required for the monitoring of the ventilation is capnometer. It's a device basically used to measure end-tidal CO2. It gives us the information about the ventilation. There are two types of capnometer: mainstream capnometer and side stream capnometer. Mainstream capnometer basically a device that is attached to the endotracheal tube, and it gets air directly from the tube, and the sensor is there on the hub of the ETT, and there will be no delay in the response. We'll get response very quickly, but it is very heavy in case we use it on the infants or the small child. It can cause the dislodgement of the ETT. In that case, we use the side stream. Side stream is basically a tubing that that is attached to the analyzer, that is attached with the monitor. It takes the a part of breath from the ETT, and the sensor is the part of anesthesia machine. It senses the patient and CO2, and it is digitally present on the monitor. This sample tubing may be 6 or more feet long, depending upon the location of our machine. And there can be several minutes delay before the appearance of the CO2. And there is the mainstream system is only used in the patient that are intubated. And the side stream configuration system can be used both in the intubated and non-intubated patient. And capnometer can also be qualitative and quantitative. Basically, it also tells us the precise end-tidal CO2 in range. It tells us whether the end-tidal CO2 falls in which range by changing the color of the capnometer. Basically, this is calorimetry end-tidal CO2 detector, and it consists of the piece of the specifically treated litmus paper that changes color when it is exposed to the CO2. The color is purple if the end-tidal CO2 is 3 or less than 3. It is tan in color if it falls between the range of 3 to 15 millimeter of mercury, and it is yellow if it is more than 15 millimeter of mercury. Basically, it is primarily used for the verification of the ETT placement. If the ETT is not placed properly, or it is somewhere else, like in esophagus, there will be no conduction of the CO2, and there will be no change, and it will tell us whether we have to recheck the entire our ETT and pass it properly. And what is the principle of the capnometer? Capnometer work on the principle of the spectrophotometry. It also uses the infrared radiation to make the measurement. It absorbs the wavelength of the 4.26 micro nanometer, and it is shown as the numbers and in the form of the waveform. It tells us the how much respiratory rate is there, how much CO2 is there, whether it's a hypoventilation, whether it is hyperventilation, and we have to act accordingly. This is the waveform, normal waveform of CO2. It tells us the information. From the A to B, the waveform, that is dead space ventilation. I will show you this thing. Basically, it starts with the beginning of the exhalation. The air that is present in your mouth, in your pharynx or larynx, it comes out. There is no CO2 because there is no exchange of the gases, and it will show just the light line with the baseline. That is dead space ventilation. Then there is our slope, upward slope है, ascending phase, early exhalation है. It basically tells us represent the rapid rise in CO2 concentration in the breath stream as the CO2 from the alveoli reaches the upper airway. Then there is the plateau phase of the capnographic waveform, that is C to D. It tells us that the CO2 concentration reaches a uniform level in the entire breathing stream from the alveoli to the nose. And there is a point D that tells us the end tidal CO2. Then there is the expiratory. I will show you this again. Then there is the descent that shows the inspiratory phase. The D to E is the inspiratory phase of the CO2. After that, new waveform is formed. What are the clinical application for the intubated patient? It tells us many information like verification of the endotracheal tube placement. It gives us the information for continuous monitoring of the tube during the transportation. Tube can be dislodged at any time during the transportation, and it is very much important to monitor it throughout your transport, whether we are taking the patient from one hospital to the other hospital, we are taking the patient from OR to the ICU. If the patient is intubated, it should be continuously monitored so that there is no dislodgement of the endotracheal tube. It also tells us the effectiveness of the resuscitation and prognosis during the cardiac arrest. In cardiac arrest, there is the flat line. Flat line waveform is generally indicates there is the esophageal intubation or there is the cardiac arrest, and we have to act accordingly. End-tidal CO2 also as an indicator is used an indicator of the ROSC during the chest compression. End-tidal CO2 level in the patient suspected increase in the intracranial pressure. It also determines the prognosis in the trauma patient. Adequacy of the ventilation is determined by the capnograph. These are the different waveform that shows us how we are ventilating the patient. The first one is the normal waveform, and hyperventilation, there is this saturation. If the saturation is normal and tidal CO2 is low, there is no need for the intervention, and we have to continue the same scenario that is going on. If there is bradypnea, like hypoventilation, we at that time we also have to check the hemodynamic. If the patient is hemodynamically stable, saturation is normal, there is no need to do any intervention. But there is any change in the hemodynamics, we have to reassess the patient, and then we can continue the sedation. If there is hyperventilation, then we have to check what is the problem with the patient. If patient is light, if the patient is having the pain, if the patient is suffering from some other problems, we have to reassess, and we have to check whether the ETT is in normal position, if there is some problem with the ETT, and we have to continue the sedation. It also tells us whether if there is the bronchospasm. In that case, saturation can be normal or low, and tidal CO2 can be high or low, waveform changes. In that case, we have to reassess the patient, and we have to do the intervention such as bronchodilator therapy. If there is some reason for the bronchospasm, if the patient is having some allergy anaphylactic reaction and bronchospasm is caused by that thing, we have to cease the drug administration for that thing. It also tells us if the patient is apneic, if there is complete airway obstruction, if there is some kind of laryngospasm. In that case, we have to intervene accordingly. Now I will move on to circulation. Why circulation is important? It ensures the adequacy of the patient's circulatory system during all anesthetic. And we can monitor that thing with the use of ECG electrodes and the blood pressure monitoring. For the ECG, every patient should get the ECG monitoring continuously if we are giving them the anesthesia. Even we are giving them the sedation, if we are intubating the patient, if we are using the MAC, monitored anesthesia care, in all the sedation, we have to give patient, we have to monitor the ECG. For the ECG, we have to use 3-lead or the 5-lead system. That is used to monitor the cardiac activity. We should use the 5-lead system because it gives us the information regarding the ischemia, about any arrhythmias, and it's very important to use that. But in some systems, in some hospitals, they are using the 3-lead system also. In the 5-electrode system, we include the 4 extremities, that's right arm, right leg, and left leg, and 1 precordial electrode that is neutral, and it allows the monitoring of the 7 leads, that is lead 1, 2, 3, AVR, AVF, and a single precordial lead. And we have to select 2 leads for that, lead 2 and lead 5. Lead 2 tell us about the arrhythmias, and lead 5 tell us the ischemic changes. That's why lead 5 system is more important to be used. But there are some hospitals that are using the 3-lead system. In 3-lead system, 2 electrodes are placed, right electrode, left electrode, and third one is the left leg electrode that is placed on the right side of the abdomen below the rib cage. Basically, that 3-lead system can be used to monitor the heart rate and to detect the existence of the P wave and the presence of the any ventricular fibrillation, but it doesn't tell us about the arrhythmias, any conduction system abnormalities. For that purpose, we have to use the lead 1. Sorry, V1 is required.
सॉरी मैडम,
जी,
ये आपने बताया कि लीड जो 3 है, एक लेफ्ट में एक राइट में, जो तीसरा है वो आई थिंक राइट नहीं लेफ्ट साइड में एपेक्स साइड पे नहीं रखते।
left side पे below the rib cage on the abdomen, we have to apply it.
या यू सेड राइट, सॉरी, ओके।
Okay, sorry. There are if we are using the 3-lead system, we can use the modification to detect the ischemia. It helps us. These modification can be CS5, CM5, CC5. In CS5, the right arm electrode is placed under the right clavicle. Left arm electrode is placed at the V5 position, and left leg electrode is placed anywhere on the left side. And for CM5 configuration, right electrode is placed over the manubrium sterni, and the left arm electrode is placed in the V5 position, and left leg electrode can be placed anywhere on the left side. And for CC5, the right electrode is placed in the mid-chest on the right anterior axillary line, and the left arm electrode is placed at the V5 position, and left leg electrode is placed anywhere on the left side. And it can be used to detect the ischemia of the anterior wall of the heart. In high-risk patient, we have to obtain the 12-lead ECG before the induction of anesthesia, so that we can compare if the changes are during the anesthesia conduction, or it was present before that, or it is caused by some surgical stress. And there are different factors, number of factors that affect the ECG trace in the operating system. That can be if the electrode are loose in contact, if there is no sticking because inadequate skin preparation prior to the placement, if there is the patient is having shivering, there are tremors, respiratory or body movement during the surgery, it can cause the artifacts in the ECG. ECG trace can also be obliterated during the electrosurgery. Electrocautery can cause there is the change in the ECG, and it can shown as the arrhythmias, can be shown as the PVCs or APCs. For that purpose, we have to place the grounding pad on the leg so that we can minimize the interference. There can be electrical devices that are near the anesthesia machine in the operating room that can also cause the artifact in this ECG. For minimizing that kind of problem, we have to place that electrical device away from the anesthesia machine so that there may not be any interference. And there is also the problem with the obese patient. There is also problem with the case of the obese patient. There is someone whose mic is on.
Please
Kind
keep your microphone mute. मोहम्मद जावेद खान, आपका माइक्रोफोन ऑन है, प्लीज डू इट म्यूट.
and obese patient में there is the low amplitude of the ECG. Then there is the blood pressure monitoring. Blood pressure monitoring is a very important modality. We have to measure at least every 5 minutes during the anesthesia. And it's clinically indicated if we are giving the GA drugs because they can cause hypotension during laryngoscopy. There is the sudden rise in the blood pressure. That's why blood pressure monitoring is very much important. And it can cause the increase in intracranial pressure. There can be change in cerebral circulation that can be harmful post-operatively for the patient. And the BP monitoring can be done with the use of the non-invasive blood pressure monitoring and the invasive blood pressure monitoring. But in standard practice, we use the non-invasive blood pressure, and invasive blood pressure is monitored during special type of people that are not suitable for non-invasive blood pressure monitoring, where B2B monitoring is required. For indication for the use of BP monitoring, the use of any anesthetics, no matter how trivial it is the absolute indication for the blood pressure monitoring. And contraindication, there is no absolute contraindication for the blood pressure monitoring, but there is change of modality from non-invasive to the invasive. And that condition is if we cannot place the cuff, if the patient is obese, super obese. If the patient is burnt patient, in that case, we will not be able to place any cuff on the patient arm. If the patient is having the AV fistula for dialysis, in that case, we will not place non-invasive blood pressure. In that case, we will use the invasive blood pressure. The equipment used for the non-invasive blood pressure, that is oscillometric blood pressure devices. That is operated sensing the magnitude of the oscillation in the pressure caused by the blood pressure flow. The cuff is inflated by the pump high enough to occlude the arterial flow of that limb where the BP bladder is placed, and it is released gradually, typically approximately 2 to 4 millimeter of mercury per second. Sensor device detect if there is any oscillation, if there is any change in the oscillation, and if there is any amplitude change, and there is change in the pulse pressure, and it is recorded as the systolic pressure, diastolic pressure, and the map. For that purpose, proper cuff size should be there. It should be, the length of the cuff bladder should be 80%, and width of the bladder should be 46% of the circumference of the upper arm. In most patients, BP cuff is applied on the bare skin of the forearm, but it can be also applied to the calf, thigh, and at the ankle near the medial malleolus. And the accuracy of the oscillatory method, it can overestimate the systolic blood pressure and underestimate the diastolic blood pressure in case of the hypotension. Otherwise, mean arterial pressure is the most accurately estimated pressure by the non-invasive blood pressure cuff. There are the limitation for the non-invasive blood pressure. These are if there is any motion, shivering, tremor, seizures, there is arm flex, there will be Arrhenius reading for that blood pressure monitoring. In case of severe hypotension, there will be no detection. Oscillation cannot be detected by the cuff, and there will be no recording of the blood pressure. Arrhythmia such as atrial fibrillation, frequent premature beats, that can also cause this defect in the BP reading. Then there is our invasive blood pressure monitoring. Basically, direct or invasive blood pressure monitoring, it is used in the high-risk patient and high-risk surgical procedures, and if we cannot apply the non-invasive blood pressure, if there is severe hypotension is expected, if there is beat-to-beat monitoring is required, if there is anticipation of the wide blood pressure swing. And there is also contraindication. That is not absolute contraindication, that is relative. But there is contraindication when there is no collateral circulation. If we are placing some cannula in the radial artery and there is collateral circulation is damaged, or there is some kind of abnormality in collateral circulation, it should not be placed on there, because it will hinder the blood flow of that part of the area, and it can cause ischemia of that part of the body. In case of peripheral vascular disease such as Raynaud phenomena, we should not place cannula in that artery. And technique and artery selection. There are different arteries that can be cannulated percutaneously for the monitoring of the invasive blood pressure. These are radial artery, ulnar artery, brachial artery, femoral and dorsalis pedis artery. But frequently we use the radial artery. And for that purpose, for the selection of radial artery, we have to do the Allen's test first. Allen test is used to check the collateral circulation, if it is present or not. If it is not, we have to check the other limb so that we can do the cannulation on the other hand or other artery. We should not do the cannulation in that part, in that artery, because it will hinder the blood pressure, blood circulation. There are different invasive blood pressure monitoring has a different component. It begins with the intra-arterial catheter. It includes the extension, that is starts from the cannulation to the stop car, inline blood sampling set, pressure transducer. You can see the pressure bag over there. There's the pressure transducer, and automated flush system is there, and electrode that it will connect to the monitor, where it is shown as the waveform and also in the number form. These are the component of the arterial pressure monitoring system. This is the waveform that is shown on the monitor. If we attach the invasive blood pressure monitor transducer, it shows us this kind of waveform on the monitor. The wave one is the systolic upstroke. The 0.2 is the systolic peak that gives us the information about the systolic pressure. And then there is systolic decline, that is 3. And 4 is the dicrotic notch. And 5 is diastolic runoff. The 0.6 is the end diastolic pressure that gives us the reading of our coronary blood flow. And the area below this whole waveform, it tells us the MAP, mean arterial pressure. It gives us the reading for the mean arterial pressure. Then here comes the last modality, that is standard 2/4 monitoring, that is body temperature. Why should we do the monitoring of body temperature? Because in case of hypo or hyperthermia, they can be delayed in the wound healing. There will be more blood profusing from the wound, and there will be myocardial stress due to the drop in the core temperature. coagulation system can dysfunction, wound infection can cause poor wound healing, longer hospital stay. And that's why we have to maintain the appropriate blood temperature during the anesthesia. What are the different sites from where we can get the temperature monitoring? These are the nasopharyngeal head, distal esophagus, and tympanic membrane. There is also different sites that are axillary, bladder, rectal temperature may also be estimated, can be used to estimate the core temperature. But it can cause different kind of artifacts. Pulmonary artery probes can also be used to get the temperature. And different temperature probes are used to get the temperature of the body. Nasopharyngeal, esophageal, axillary site are used. Thermistor, thermocouples, and infrared thermometer are also used. These are used to measure the temperature within the 0.5 degree temperature, change in temperature. And why we need the monitor, I have already told you, hypothermia has consistently been
Excuse
shown.
me, Dr. Uzma. Excuse me, Dr. Uzma. Sorry
Yes.
to interrupt you. We
Sorry.
won't have any time left to ask the questions and give the comments. You know, it has been almost 55 minutes from now, you know.
Sure. I'm just, I think there are 2 or 3 slides more and I will finish this off. So I have already told you all this thing, hypothermia consistently, it can cause myocardial stress, coagulation system dysfunction, wound infection, poor wound healing, long hospital stay, and patient discomfort and shivering. Other monitors that, other than the standard, we can also use, but in special patients like pulmonary artery catheter for cardiac output monitoring, central venous pressure monitoring for volume status in case of large fluid shift, even urine output if the case is prolonged, if there is a large fluid shift, if we are worried about the kidney status, we have to use the urine output. And this is the take-home message that we have to use visual inspection, auscultation, palpation is the primary determinant of the patient safety. And it can also, it only can be done if we are vigilant enough to do the things. We have to be very vigilant during the anesthesia care. We have to use devices only to aid our observation, and we have to detect early, and we have to do the things accordingly. Thank you. And these are the articles from where I got my stuff and data. These are the new articles that are shown on your monitor. And that's it. Thank you.
Thank you, Uzma. So we have few questions over here. Fatma want to know about which site is most accurate for core body temperature monitoring.
For core body temperature, there is tympanic membrane that is used for that purpose. It's less artifact is there, and it gives us the more accurate reading for the core body temperature.
Okay. Dr. Ali has a question.
Yeah.
He want to know about the, you have mentioned about the standard one. What do you mean by a qualified anesthetist? How we can define a qualified anesthetist?
By qualified anesthetists that have done his training and is doing at least 2 to 3 to 4 years of its anesthesia and vigilant anesthetist that can detect early change in the pathological and physiological changes in the body in the patient, that can be called as the anesthetist. That can be called as the Sorry.
So any person who has obtained at least 2 years of the training from a tertiary care center fulfills this standard. And there is another question. What is the advantage of pulse oximetry over the clinical judgment?
Clinical judgment, pulse oximetry shows us the digital number, it shows us the saturation, and the cyanosis and dusky appearance. It appears very late, and digitally it is a very early detection of the drop in the saturation, and we can do our things early. Clinical judgment is also important, and saturation aids that our things, but cyanosis and dusky appearance appears very late, and digitally it's more accurate, and we can record the things that it's giving us that.
Okay, so it gives the early warning sign of the
Yeah.
any deoxygenation if it is underway. Okay, there is a comment they've asked about the pain is the fifth vital sign. I think you have told that oximetry, I guess, is the fifth vital sign. So here is a comment.
It's called
Someone
the
has
fifth
mentioned that.
vital sign. Yeah, pain is not the fifth vital sign. Pain is basically a symptoms that a patient is feeling while undergoing surgery, while undergoing laryngoscopy, while having the endotracheal tube. That is just a symptom. But oximetry, because it gives us the data about the perfusion of the tissues, and sixth vital sign.
Okay, so it's a little bit a debatable thing because a lot of literature, what I have seen is they've mentioned, especially if you go on the International Association of Study of Pain, they have mentioned the pain as a fifth vital sign. So officially, so there's a debate on it. Okay, another
This is
question
new
is,
modality. This is not very old. It's a new thing, and I read about it, and it tells us whether the body is adequately perfused, if it is having the oxygen saturation, its a partial pressure of oxygen is adequate for the tissue perfusion, and tissue is not on at anaerobic respiratory threshold. So that's why they are called it as fifth vital sign.
there is a question, what is the advantage of monitoring 5-lead ECG over the 3 leads?
Basically, I told them the 5-lead ECG tells us the about arrhythmias, and there is ischemic changes are detected very early that are not shown on the 3-lead ECG. 3-lead ECG will only tell us about whether there is fibrillation or not. It will only tell us if there is P wave is there or not, and it will only tell us the heart rate. But in 5-lead ECG, ischemia can be detected early.
Yeah, it is more sensitive, around 85% is sensitive in detecting
Exactly.
the intraoperative.
Exactly.
Okay, so no more questions. So we have Professor Akhtar Wahid Khan is with us. Sir, if you could please give some comments.
I think he's not there.
Okay. PSA Karachi President Dr. Shabir Jumani is with us. Sir, if you could please give some comments.
Thank you very much, Dr. Azhar, for asking me to give some comments and my suggestions. Very good lecture, no doubt about it. But I would advise, the persons who are giving the lectures, to stick to the time. Time management is very important, and the only
Yeah.
thing, to manage it, to have a rehearsal, before that, and that's the only way, we can manage the time. And number two is that
I
we
know.
are here.
So basically, this is very vast. Sorry?
This is the beauty of our lectures. If it is vast, or how to condense it and to present it, to learn how to present anything in just 1 hour's time. And that's
Yeah.
how we learn. And the other thing is that we are here, to discuss the recent updates and guidelines, of any subject, right? We are not here to discuss the anatomy, physiology, and how these monitors work. We all know these things, the
Yeah.
interpretation, of the monitors, and then recent updates and guidelines are very important. If we just stick to these things, then we can really condense our lectures, and we can save the time. So then there is a time to ask the questions. Questions are very, very important, in any lecture or any presentation, or in any CME. We have a lot of questions in our mind, but we don't ask because of the two things. Number one, we are shy, and number two, we don't have time. So time
Yeah.
management is very important. Many times, I've told my, my lecturers, to stick to the time, and that is the only thing. Thank you very much.
Thank you, sir. Thank you for your feedback.
Sorry, I want
Thank
to
you, Doctor.
say something.
Thank you, Dr. Uzma. So with this, we come to the end of this interesting topic. I will request all the participants to fill in the feedback form. Thank you.
Sorry, sir. Madam, you are here?
Yeah, I'm here.
Madam, you said that jo clinical, I think cyanosis of periphery, other things when there is hypoxemia, it appears late and pulse ox detects it early. I think there was other factor like CO poisoning, methemoglobinemia, or self-hemoglobin. These
जी,
can be detected clinically, no?
they
If
can be
pulse ox does
detected
not.
clinically, but unka basically the monitors are to aid our clinical judgment.
Yeah.
And if there is hyperpigmentation, or if there is some kind of other problem with the patient, then digital monitoring is prime monitor that we use for this purpose.
Okay.
Basically, I saw a patient was working in the salon and was doing dye on the patient, and his hands were blue before that, but they were not cyanosed. And for that purpose, we have to use the monitor, and we have to obtain the blood gases to get the proper data. And basically, these data is also important for our record. Clinical judgment
Yeah.
cannot be recorded. We can only,
Okay.
this is personal judgment. But digital judgment numbers, they are basically records.
Okay. And another thing you said ki like he was working at salon. These are nail polish or some other things. These factors are also affect the readings of pulse ox.
There are different factors that affect the readings: nail polish color, and different methemoglobinemia, such as anemia. These can also, there will not be any cyanosis, but these can cause change in the digital data of the patient.
Okay. Otherwise, the lecture was good, madam. Thank you for
Thank
that.
you. Thank you.
I'm not a
Sorry?
unmute केवल या
जी अनम्यूट कर दिया.
Sir, खुश आयो.
Lando.